it's a great pleasure to introduce Chris Beyrer, who is really a tremendously internationally recognized epidemiologist and human rights physician. Chris has worked in the front line of HIV, AIDS, and COVID-19 treatment and research, but really at the intersection of health and human rights and social justice. Really much of his work centers on securing health equity for underserved communities. He's committed to collaborating with local healthcare providers and leaders to achieve this. He's worked with vulnerable populations from around the world, including the Rohingya refugees in Myanmar and populations suffering from HIV and AIDS, particularly in Thailand. He helped lead global efforts to provide AIDS care and antiviral therapy across Africa and the developing world. And since last August or September, he's directed the Global Health Institute at Duke, which is a new job for him after having spent how many years at Hopkins?
30.
Okay, well, maybe I shouldn't say that.
31.
Okay,
Yeah.
well, all right. But before coming to Duke, he was the inaugural Desmond Tutu Professor of Public Health and Human Rights at Hopkins, and he was also there, obviously, a professor of epidemiology, international health, and medicine. And while he was there, he actually founded the Center for Public Health and Human Rights, one of the first human rights centers in a public health school anywhere.
Yeah.
The center is home for, quote, Safeguarding Healthcare in Conflict Coalition. I think we'll hear a little bit more about that, and which has really led to the successful effort of WHO monitoring health attacks on physicians and facilities. The Russian war in Ukraine is really the conflict where a lot of this reporting is being done now.
Yeah.
And it's really a huge advance in accountability. It's really the first time that we're counting how many healthcare workers and health facilities are being attacked. Chris is the past president of the International AIDS Society. The past president?
Yeah.
Okay.
Yeah.
This is a huge body of HIV researchers. He served as an advisor to PEPFAR, among many other international agencies. He's incredibly prolific. He has more than 400 publications. He's recognized in 2022 as one of the world's most cited scientists, and he was elected to the National Academy of Medicine and serves on the Academy's Board of Global Health, and also on the Committee for Human Rights. It's a nice committee to be
Yes,
on.
indeed.
So anyway, thank you for joining us,
Thank
Chris.
you, Michelle.
And I think Paul Costello needs no introduction, but he's been I'll introduce him anyway. He's been leading these conversations for how many years now, Paul?
Many.
Many years. Well, since I've come, because
Yeah.
you and I started together.
Yeah.
He served for 16 years as the Chief Communications Officer at Stanford School of Medicine. He's a faculty member of the Center for Innovation in Global Health, and he's really a very talented interviewer. So I'm going to let him take it away, and hopefully we'll get to the real depths of who Chris Beyrer is. Go for it.
Thank you, Michelle, and thanks everyone for being here. You know, I never know where I'm going to start at this. You know, I've put my papers together, questions together for weeks and weeks and weeks, but Michelle said something. She just dropped in, and I think I want to start there. You have put together and joined together human rights and health. And that sort of is, I don't know if you'd say new, but it's sort of a concentration that you think is important.
Yeah.
Why is that critical, and how do you help that spread?
Yeah. So, you know, my training is in epidemiology, infectious diseases. How's the sound, by the way? Is the volume okay?
The microphone's rubbing against me. If you put it on the outside, so it'll help.
Sorry for that. That better?
Much better.
Okay.
Much better.
Okay, good. And we have powerful tools to look at populations, the health of populations. And one of the things that unfortunately has been emerging in the human rights world and certainly when we started the center, it was a very big part of it, is that most of the methodologies that were out there were from lawyers and journalists. And human rights was very much nested within the law. And they look for one really good case. And the classic example of this was Amnesty International, which had documented the disappearances and the killings of social activists and journalists in Guatemala. And then in their own review of their efforts over many years, realized that they had missed the genocide of 400,000 indigenous people because they were unknown and unnamed. And they were being targeted because of who they were and because they were indigenous and living on land that powerful people wanted. And so I really felt that it was incredibly important that we bring to the human rights world the tools of modern population-based science. And that includes epidemiology, molecular epidemiology. We've used satellite imagery, which has now become more and more a part of human rights documentation, a whole array of tools. And on the other hand, the medical world and the public health world, it seemed to me, was insufficiently paying attention to human rights as an understudied social determinant of health, which is, I think, what human rights really fundamentally are from a health perspective. And so we created this center to really try and come at this problem from both directions. And at the time, it was the first in a department of epidemiology. And now I think it's very much accepted that there is really an epidemiology of how to assess human rights violations, how to impact them. And happily, we're really in now a period where we're starting to see interventions that really matter.
Has it caught on with leaders like Tony Blinken and others, Secretary of State and global leaders, secretaries around the world? Is that coupling of it caught on?
Well, I think we've had some impacts on a number of countries, including the United States. I would say that this work really had a lot of traction with the Obama administration. Just give you one concrete example that there was an election, stolen election in Zimbabwe. There have been several stolen elections in Zimbabwe, but this particular one, 2007 and 2008, led to a collapse of the healthcare system and a cholera epidemic, huge cholera epidemic, and there was a political stalemate between the opposition and Mugabe's regime. And the elders, people familiar with the elders, Nelson Mandela, and so these three elders, Desmond Tutu, Jimmy Carter, and Graça Machel, who was Mandela's widow, all tried to go to Zimbabwe and broker a peace. And they were denied visas. So then, incredible, right? And then the suggestion was that then a covert investigation should be undertaken, and they needed somebody to do the epidemiology part of it. And Physicians for Human Rights put this together, and I agreed to go. And it was really one of the most extraordinary things I've ever seen. It was truly a collapse of a healthcare system and an economic collapse in the country. And we came back, and it was 4 days after the inauguration of Barack Obama, and we were in the State Department, briefing the administration.
Madeleine Albright was secretary.
Yes, and they were completely interested in both the data that we had to share and also in understanding the links between what was happening. Cholera is not normally seen as a human rights issue, but it profoundly was in this case. And essentially what had happened was Mugabe lost the municipal elections in every major city, and then they just starved the opposition of money, and there was no water filtration going on. And if it wasn't cholera, it would have been some other waterborne disease.
So let's go back to, you were raised in Switzerland, or you were born in Switzerland. You came over to Long Island.
Amazing Long Island. Yeah.
Amazing Long Island. And your father was a physician. Your mother was a newspaper editor and a poet. What influence did your parents have upon your life, your early life and continuation?
Well, So I was very fortunate to grow up in a very literary household. My mother was a writer who loved good writing, and she was a person very passionate about the arts. And so we were always going to museums and being exposed there. And I, early on, had just a passion for nature and for living things. And I was just thoroughly indulged. I raised guinea pigs. I had tropical fish tanks. When I was about 12, I got into breeding and showing Old English sheepdogs, which I was allowed to have, grooming away, and my parents, indulged all of this. And I went to public school, East Islip High School, and it was not a great school. And at a certain point, my parents found a guy who was actually a local cancer investigator who let me hang out in his lab and do work there. And then my mother found a writing tutor for me, a wonderful drunken old English novelist who was a great person. And she came once a month and we would do writing stuff together. And I had I think, an extraordinary education. I'm a gay man, and I started, going through that awakening as an adolescent, and I was just very fortunate to have, it was the 70s. It was an early
Accepting
time,
parents.
but yeah, very accepting, and fortunately for me, people who just had that unconditional love that just helps people grow.
You described that you had this sort of idyllic life until you got to New York, and how dramatically that changed. So you went to college in, I believe, Maine?
Upstate New York.
Upstate New York,
Yeah,
and then you
Hobart.
went to med school in New York.
Yes. Yeah.
Oh, why do you roll your eyes?
So, there are 5 medical schools in New York City. It's the only city in the United States with 5 medical schools. And 4 of them are in Manhattan, essentially. And one of them is in East Flatbush, Brooklyn, which is the SUNY school, State University. And that's where I went to med school. And it was in a very rough part of the city, but you just have to remember what the early 1980s were like. And it was the AIDS epidemic was just unfolding on New York City. And at one point, 9% of all pediatric HIV cases in the United States were our patients. It was just, an overwhelming burden. And it was untreatable. And, so you're taking care of patients, you're trying to learn how to do this, you're seeing these young people dying, and you have to remember Ronald Reagan was president, and he was not funding the cities. New York City Health and Hospitals Corporation was going broke. The first time I walked on the wards, a nurse gave me a list of people who needed IVs. I said, somebody has to teach me how to do that. She said, you are all I have. And it was chaos, and it was a very heavy time.
And you had a lot of friends who were HIV positive and had AIDS, and your lover.
Yes, indeed. Yes. Yeah.
Ed.
Yeah. An amazing person.
One of the things that struck me, when Steve Jobs was sick here in California, in Palo Alto, the irony struck me that as rich as he was, he couldn't do anything. He couldn't change his trajectory.
Yeah.
And it seems to me, for you, you're a healthcare worker, you're a healer, and they're in front of you, and you're dealing with HIV pediatric patients, and there in front of you is your lover, and you can't do anything.
Yeah.
And the powerlessness that you must have felt from that, what was that like?
Well, it was terrible, to be honest with you, and at a certain point, I took a break. So my partner, he was an actor, he was a New York actor, he was a beautiful man, and of course, at the time, you have to remember that in this country, same-sex couples were essentially legal strangers. So you had very few rights or protections of any kind. And he basically started to get ill when I was in medical school, and then through internship and residency, and he died just as I was finishing my training at Hopkins and doing an ID fellowship. And I took a break, and I really had no idea what I was going to do. And I finished a book that he had started. And then I was kind of really wondering, right, how am I going to deal with all of this? And Hopkins got an award, an NIH grant, to start HIV vaccine trials in Thailand. And I got a call to say, you know, we need somebody who can go to Thailand in a week or 2 weeks, you know, and somebody who's worked in vaccines, which I had done, and trained in epi, which I had done, and worked in HIV, but it was going to be about prevention, vaccine research. So, and I thought, I'm going to do that.
And this was after Ed had passed
Yeah,
away.
yeah, a year after, yeah. And I initially went for 2 years. I had a 2-year contract, and I ended up staying for 5 years, and really working across the region, working in Burma. This is where I got involved with Burma, Myanmar, Laos, in southern China, in Cambodia. I taught in Malaysia, taught epi in Malaysia, and it was really life-saving and also really, really formative work for me. And we were incredibly optimistic and naive about how long it was going to take to get a vaccine. We were thinking, you know, like 5, 6, 7, 8 years, and that was 1992 to 97, and here we are. We just had 2 big vaccine trials that were just complete failures.
We talked about that a minute ago, and,
Yeah.
about the lack of a vaccine. What are the complications of it? Why is it so impossible to, you
Yeah.
know, come up with a vaccine?
You know, the contrast between HIV vaccine work and the COVID-19 vaccine work is just so striking. So one of the things that people don't always appreciate is that the reason we were able to do the clinical trials for COVID vaccine so quickly is because we used the infrastructure that was built for HIV vaccine trials. So that's how I got involved, because, you know, we have vaccine trial sites all over this country. And we needed to do 5 trials with 30,000 American volunteers each in 6 months. And that could never have happened without the investments in HIV. So it was an extraordinary thing to be a part of. But coronaviruses have a spike, and that spike protein, which is the attachment point to the human tissues, or other animal tissues for that matter, is the target, and it turns out it's really pretty easy to neutralize it. HIV is a completely different pathogen, and the normal human immune response to it is part of why it kills you. So there is no natural immunity, except for a tiny proportion of people who have genetic resistance. And otherwise, you know, the basis of whether or not you have HIV infection is still the HIV antibody test. And if you're making antibody, that's our nice, normal human immune response. Untreated, it will kill you.
Let's go back to Thailand. What was the difference? Thailand is a very data-driven country
Yeah.
in many respects. So I presume that the difference in Thailand versus the surrounding nations like Burma
Yeah.
and Cambodia and their failure at attacking HIV, is that the success of, is that what you can pinpoint as the success of Thailand versus the neighboring countries?
You know, it was an extraordinary thing to be a part of a research effort where every time we had an important finding, you'd go to the government and they would implement it. It's like unheard of, you know, that people actually do that and listen to scientists. And I'll give you an example. We were working with the Thai Army, which at the time had the highest rates of any army in Asia. It was mostly because of basically high rates of use of sex workers by these soldiers. You know, I briefing the Surgeon General of Thailand, and I said to him, you know, I think there's programs that we could do around this. We really need to encourage condom use in brothels, and you know, there's a whole way that this could be made safer. And he looked at me and he said, "Okay, yes, except remember one thing. These are young Thai men, so make sure you keep the sex pleasure." And you know, it's a very real recognition of the humanity of all of this. We also found that Thai soldiers who had sex with men had higher rates of HIV infection. So I said to him, we're going to have to include safe sex for men as well, where men were having sex with men, to which he said, good. And, this was at the time where we were dealing with Don't Ask, Don't Tell, and a firestorm of politics about gay people serving in the military in this country. And the contrast was just so striking. But there's another aspect to this, which is something you understand the longer you spend time in that country, which is that it's the only country in the whole region that was never colonized by Europeans. And so it has an intact culture that is really its own thing. And it's sex positive in a way that most Western societies are not. They are not conflicted about many issues. And people often spend time there and just sort of, can't believe how, for example, there's a third gender, there's trans people have been a part of that culture forever. They have their own kind of language and dialect. And it's just, part of the society. Again, an issue that is tearing this country apart right now.
During the Uganda in the past week, implemented a really dangerous, horrible law.
Yeah.
And I remember you told me earlier when we spoke of your efforts earlier during the Clinton administration, I believe, and you got Hillary Clinton, and during the Obama administration, you got Hillary Clinton involved. Talk about that period and what happened between, the success of that period and what happened this week.
Yeah. So 2012 was the first time the Ugandan parliament started putting together this very anti-gay bill that included, in the first drafts, the death penalty for something they called aggravated homosexuality, which is kind of like, what is that? And nobody knows, but it's very aggravated. It was a very draconian law, and at the time, Barack Obama had recently gone to Kenya. And he'd had this sort of powerful experience, connecting with his family there and meeting his grandmother. And he had spoken out about LGBT rights in Kenya, and it went over very badly. So when this Ugandan bill was put forward, there was an emergency meeting at the White House. I was very much involved in the IS leadership, so I was, invited. There were about a dozen of us. And the idea sort of emerged that it turns out that the draft of the law had actually been written by U.S. evangelicals. It was not written by Ugandans. So we needed to counter that with a Christian voice, and everybody agreed it should be an African voice. So I, of course, knew Archbishop Tutu and had worked with him, so I said, I could ask Tutu. He might, be willing to weigh in on this. And of course, he was more than willing, and I drafted an op-ed for him, which went viral. It started in the Washington Post. It was covered all over Africa, and in which the argument was made essentially that these anti-gay laws would look, in retrospect, as bad as the apartheid laws. That would be the analogy. And Tutu, he was a great texter. He loved to text. We were texting back and forth. He texted me at one point, and he said, I have one sentence I want to add to this piece, and you must find a place to put it, and this is the sentence. I would not worship a homophobic God. I mean, is that a sentence? And so we did weave that in. But it was I think a very it was an extraordinary time. Hillary Clinton subsequently, one of her most famous statements was from when she was First Lady. She went to the Beijing Women's Conference, right, and she said women's rights are human rights, and human rights are women's rights. So she did the same thing at the UN, saying gay rights are human rights, and human rights are gay rights. Yay, And then John Kerry carried that forward and put forward a directive to all U.S. consulates and embassies worldwide that people seeking political protection, seeking asylum because of persecution for sexual or gender minority issues, have the right to do that. We are open for business. And that was an incredibly important step. Fast forward to now, so a number of other countries have passed these same bills. They're always anti-propaganda bills. And they mostly have been written by these same evangelicals.
What do you mean by that, anti-propaganda bills?
So, for example, it was already illegal to be gay in Uganda, But what this bill advances is it's couched in the language of anti-homosexual propaganda, so that it is illegal to recruit people. It is illegal to organize or to teach or to have books or curriculum. So, if you're hearing echoes of the kind of book burning that's going on in this country, that's what it's about. Nigeria did the same thing, and theirs is also called, I think it's called the Protection of Marriage Act, but it's essentially the same thing. And then the Russians did the same thing with the same language, and theirs is an anti-homosexuality propaganda law. I was working in Russia doing, we had a huge program funded by the National Institutes of Health, running the only truly anonymous clinic for gay men in Moscow. And they shut us down after that law was passed because it was seen as it was legal to be gay, but it was illegal to be providing services.
Since you mentioned Russia,
Yeah.
draw the connection between Assad, Syria, Russia, targeting healthcare workers, targeting hospitals,
Yeah.
and how that has sort of become now commonplace in
Yeah.
Ukraine
Yeah.
and elsewhere
Yeah.
in the world.
Yeah. Well, the standards for over 100 years, really, as we were hearing actually a great lecture on the history of this morning in Michelle Barry's class, has really been that healthcare facilities, emergency healthcare workers should be exempt and protected in conflict. And there's this presumption of medical neutrality, that healthcare providers are there on a neutral basis and they are meant to be protected. And in the last 20 years or so, but particularly in the last dozen, that has totally been turned on its head. So what you have now, and it really started in a major way when the Russians came in with the Assad regime in Syria, is deliberate attacks on healthcare and healthcare facilities, bombing of hospitals, killing of healthcare workers, targeting ambulances as a tool of terror. Right? This is a tool for essentially trying to break the hearts and minds and backs of civilian populations. And it's also a tool of ethnic cleansing. So, for example, in Tigray, in this terrible civil conflict in Ethiopia, the Ethiopian army set about destroying the entire healthcare infrastructure of Tigray. So there has never been a mechanism for documenting and confirming that these things were actually happening. And this was the Safeguarding Healthcare in Conflict Coalition that was housed in my center, took this on starting about a decade ago and said, the process is essentially you have to go through the World Medical Assembly to, get a recommendation. You have to get it to WHO. And now that is happening, and the Ukraine conflict is the very first where WHO is not just documenting but also confirming attacks on healthcare facilities, healthcare workers. And of course, it is exactly the same. It is being used as a tool of terror. It is, it's not like there's fighting between soldiers and then there are atrocities on the side. This is a war of atrocities. That's the point. And the targeting of healthcare workers is a part of the terror and meant to cow the Ukrainians. And that is, it's a horrific change in our world. It's one we all have to resist in every way that we can. There can't be impunity for this kind of thing. Right? It's a war crime to attack a healthcare facility. And that I think really, and strikingly, the WHO under the current director has just refused to do this in any other conflict. They've only done it in Ukraine because of the political pressure to do so.
Have the Geneva Convention has that been watered down? Those are very specific about war crimes.
Yeah. Well, we seriously undermined them during the Bush administration and during the war in Iraq, as you will recall. And the U.S. military has always been incredibly strong about torture and prevention of torture because we don't want our own people to be tortured. Mm-hmm. And we had people like John McCain who had been tortured for 5 years in Vietnam and knew that everything that he said in those terrible years was just a lie to stop the pain. He always stood up for this. We had, and Stanford unfortunately was involved, a redefining of torture to a very extreme level, essentially to say that nothing is torture unless it leads to imminent death or organ damage, which is a pretty high bar. And the reality there is that those were war crimes. They were done in our name. They were paid for by USAID. The two psychologists who came up with how to do these tortures, particularly for Arab men, the forced nudity, the dogs, all those things, it was all psychological. They got $67 million in USAID grants to do that work. We outsourced the architecture of torture to these people and paid for it with our taxpayer dollars. And there was a real groundswell of the human rights movement to say this has to stop, this can't go on, and also that there can't be impunity. And I think I love Barack Obama and I voted for him twice, don't get me wrong, but one of the really, I think, fundamentally terrible decisions that he made very early on was to say we're not going to prosecute these people. There is not going to be a war crimes tribunal. We are not going, because the country needs to move on. We need to end these wars, and we are not prosecuting any of these people. And that set a terrible standard for impunity, honestly, because there is no impunity for torture. There is no statute of limitations on war crimes. And as you see, if you follow this and look at it in history, sometimes it takes 40, 50 years. Right? The South Korean comfort women are still trying to get justice from Japan, from World War II.
So what is the impact when the Arab League welcomes back Assad with great fanfare into their community? What you were just talking about how other things impact, other nations. What's the impact when leaders look at what the Arab League is doing and how they are sanctioning Assad and its genocide, quite frankly?
Yeah, I mean, there's nothing worse than what Assad has done to his own people. He crossed the line, into using chemical weapons against civilians. It's absolutely a war crime. Bombing healthcare facilities, bombing civilian targets. And he was absolutely, particularly after the gassing of the Kurds, essentially seen as a pariah and excluded from that circle. But the dynamic, all kinds of dynamics are shifting because of what is happening in Ukraine and in other conflicts. And he's being rehabilitated. And he's going to prevail. That regime looks like it's going to stay on. And that will mean that it will be another kind of landmark for impunity. That you could do this to your own people and get to stay in power. Until recently, there was a sense that we were really making headway in this area, and there were actually sitting heads of state who were charged, like the dictator of Sudan, like Charles Taylor in Liberia, and held accountable and tried. The general who led this coup in Myanmar and the genocide against the Rohingya is indicted for war crimes. There are a very limited number of countries he can go to without being arrested. Pinochet, the Chilean dictator, was arrested in the UK. I mean, so, this, and by the way, there are a number of cases against people in the Bush administration pending in Spain. John Woo, who wrote the torture memo, cannot set foot in Spain without being, arrested for crimes against humanity. So, there is power in these tools, and we need to use them.
You've been very involved in Myanmar with the Rohingya and their fight for survival.
Yeah.
And tell me about, you said this morning that Aung San Suu Kyi is a friend. And where do you hold her accountable for what happened? And where do you give her room and space for?
Yeah. So Aung San Suu Kyi, people familiar with who she is, she is an extraordinary human being, and she had an extraordinary fate sort of thrust upon her. Her father was the founding general of this country. He was assassinated when she was a little girl, and the country descended into this long-standing military chaos. And she was an Oxford academic, and she married a British academic, and she said to him early on in their marriage, "You just have to know that at some point my country may demand, it may be put upon me that I have to go back, and I can't not do that if it happens." So they lived a somewhat conventional life. He was the world's expert on an esoteric form of Buddhism in Bhutan. Michael Aris, he was a Buddhist scholar. They lived in Bhutan. She worked for the UN there. They had children. And then there was an uprising against long-standing military rule in 1988. This is the revolution. It's called 8888, August 8th of 1988. And people stood up in enormous numbers and opposed the general, Ne Win, who'd been dictator for 30 years. And she went back, and and unarmed and doing a Gandhian nonviolent civil disobedience, and took these people on. She famously walked across sniper alleys. I was in her compound, literally briefing her on HIV when they had a sniper on the roof aimed at both of us. And she was saying to me, "Pay them no attention. They're there every day. Please go on. Please proceed with the briefing." It was really, she was an unbelievably brave person. But she won that. There was then an election in 1990. She won it, and then they put her in house arrest for the next 6 years.
And she's in solitary confinement now for
She's won every election she's been able to run in, and she won the last election by an overwhelming majority, and this led to the coup. And now she's in prison. But I think the mistake that she made, which was not only hers, there were a number of people who played a role in this, was that the generals put forward an incredibly anti-democratic constitution. Their argument for why they never let her take power was, "We're rewriting the Constitution. It's just going to take us 16 years, But eventually they put forward this constitution. And it included a clause that the civilian government could be dismissed at any time of national emergency by the military. So that essentially says, we'll let you do some things, but if you cross us, you're gone. And she didn't want to sign it, and she resisted it. And the U.S. had no stomach at the time for a fight. Nobody wanted this to go back into a military conflict. And Hillary Clinton personally went to Rangoon and said to her, "You should sign this. You should agree to this constitution and these terms." The pressure was very intense. The UK wanted her to do it as well, so she did. And then this is precisely what happened. The general lost the election. That was his emergency.
And she was imprisoned.
She is in prison, and she has no contact with the outside world. She's in a military prison. She's 79 at this point. She has children in the UK and in the United States, and grandchildren that she's never met.
You're a Buddhist, and you've been for many, many years, I think since high school, actually.
It's true.
How
It's
is
strange,
Buddhism
but true.
impacted, inflected
Yeah.
your life, your career,
Yeah.
everything you've done?
Yeah. Well, I think profoundly. I think really profoundly, because one of the kind of tenets of Buddhism is that you have to have fidelity to the practice and to the process of what you're involved with and trying to do. You really have to stay in the process. But you have to have some non-attachment to the outcome, because the outcomes you really can't control. And they often go badly. And if you engage in things like epidemic infectious diseases and human rights, you are going to have some setbacks, and it is, if you take it in too personally, it can really be undermining. And I've seen people get to a place where they can't function. And Buddhist practice really helps you keep equanimity. It helps you keep to a middle way, which is a balanced approach, you know, and I have found over the years, I never give a public talk, I never teach, I never do anything without first trying to make an offering of it, and to hope that whatever is said, whatever is heard, opens people up to compassion. That's the plan.
We'll end there. Take questions from the group. Thank you so much.
Thank you. Oh, sure.
No, I'm going to turn off mine.
Oh, okay.
Questions?
I'll start if no one else will. First of all, thank you for this talk. Really appreciate it. And I think I want to ask you
Can you
about-
identify yourself?
Oh, I'm sorry. My name's Jerry Grayson. I'm not affiliated with the university, but I have a deep interest in global health. So just curious, first of all, your assessment of the role of molecular testing, NGS testing, in global health, where it stands right now, where you think it needs to be, what kind of potential or promise it has with respect to some of the early warnings that we've seen with some of the NGS around COVID, especially with respect to some of our sanitation systems and that kind of testing. But how can we make that sort of approach to global health so we have better population indicators? How can we make that more a reality?
Yeah. Yeah, it's a great question. Well, you know, we have used molecular tools in many disease systems, and molecular epi has helped us understand a great deal about HIV and TB, you know, and a number of other infectious agents. I think, you know, a big part of the challenge, and it's always true with technology, is that there has been hugely uneven gaps, right?
Exactly.
So, for example, with what became very clear with COVID was that the South Africans were picking up these new variants, including, you know, the Beta variant and Omicron itself, which is now the only virus circulating. And we really don't know where those emerged or what the molecular mechanisms were. But we do know that they got picked up in South Africa because they're the only country in their region with the technical capacity to do that. And so we really need to extend and expand that capacity. And, you know, I think everybody is looking at pandemic preparedness. The next 10 years, for those of you who are interested in global health, the next 10 years, pandemic preparedness funding is probably going to be, you know, the substantial resources that are coming into this field. There isn't likely to be much else new. And, you know, so everybody is looking at how to increase surveillance networks, work with molecular tools. I mean, Michelle is a great expert in this. But, you know, we'll see if we do better this time. You know, the WHO does not get terribly high marks in the evaluation of the COVID response.
Right. So, since I'm holding the microphone, quick follow-up. And you alluded to this in your answer, the need to expand the ability. But we're looking at informatics as being a pretty high bar, a pretty high threshold for the expansion. Do you see that there are things happening in that space that can make it more accessible for under-resourced communities in the next 2 to 3 to 5 years?
Well, you know, there's been an explosion of information technology, obviously, and there's lots and lots of countries, places that are doing this and they're actively doing it. So I think the question isn't going to be necessarily if it happens, because it's going to happen, but much more sort of how do we do it in a way that gets to the last mile places, which is where a lot of emergence happens,
Right.
and that, and is done in ways that protect populations and communities.
Right. Do you see last mile work underway right now?
Well, Raj Punjabi is head of pandemic preparedness in the White House, and he started Last Mile Health. So that's a good sign. Do you know Raj?
I do
You
know,
must know him,
yeah,
yeah, me
yeah,
too,
because-
yeah. He was a student of mine at Hopkins, yes.
Yeah, my name is Jotam. I'm actually from Zimbabwe.
Oh,
so
hey.
I'm very
Do
familiar.
you remember that cholera epidemic?
Yeah, I was actually an epidemiologist in the ministry when it started in Bedbridge. So I managed that the first wave in Matabeleland South and in Mashonaland West, where I was the epidemiologist. So I am quite aware of the politics that happened when all these NGOs were coming around trying to bring in IV because the ministry was just in the process of collapsing. So So and actually, thank you very much for that work. It brought in a lot of resources, but unfortunately, those kinds of efforts never get to change governments.
No, not in that case. No.
Yeah, but I'm not going to talk about Zimbabwe. My question is actually on your thoughts on post-infectious diseases, sequelae. How we would quantify that and use it as a tool for leveraging resources to better prepare for epidemics, because we know from infectious diseases that there are patients who will die. There are also patients who will have severe sequelae, and usually these are not the ones that we target during an epidemic. Our aim is usually to prevent deaths, but it is usually in those survivors that actually bear the brand of the disease. I mean, I've done that in tuberculosis, and we've learned a lot. And I just want to hear your thoughts. And even how we can use that as a clinical endpoint for both prevention and other targeted interventions. Thank you.
Well, it's an important question. I guess I would say, that there's no more compelling example right now than long COVID, right? And the enormous numbers of people who are continuing to have lasting sequelae. And because it's a new disease, and also because there were multiple variants of it, it's a protein complicated outcome which is highly variable. And if you look at it just in terms of pure increase in disability, say in the United States, it's the largest increase in disability in the United States since Spanish flu, which also had some strange sequelae, the encephalitis lethargica, that was rare, but lifetime debilitation. So, I think it really is an important aspect of this, and there are almost certainly a number of other conditions, and everybody kind of knows this, that are post-viral syndromes. Some of the demyelinating diseases probably fit in this category. So does juvenile diabetes, likely. There's an array of post-infection autoimmune diseases that we don't really understand very well. And that's also, I think, going to be a really important part of research and effort. It's interesting, that everything in biology that confers an advantage has a price, right? And of course, women are stronger than men, right, considerably. And they have twice the immune response repertoire for a number of diseases because of having two X chromosomes. They have substantially higher COVID resistance than men. In every population, there's 50% more death in men than women with COVID. And it's because the COVID immune response genes to coronaviruses are on the X chromosome. But the flip side of that is that these if they are post-viral autoimmune diseases, are consistently more common in women. Lupus, rheumatoid, sarcoid, MS, there's a long, long list. And I think that's an example of the sort of the why these immune response genes are conserved and why they also, can really lead to post-infection sequelae. There's a huge body of work around this, trying to work on it. Duke got, where I now am, got the contract for the long COVID cohorts in clinical trials, which is, a huge undertaking. But there's no way to do it except with a cohort. We're going to have to follow people prospectively and understand how they do.
Question?
I'll just start. My name is Natasha. I'm one of the second-year global health residents
Oh, great.
of the residency here. As someone who's early on in my training, I think I spend a lot of time thinking about partnership.
Yeah.
And so I was wondering if you could speak a little bit to the role that partnership with local institutions or local agencies has played throughout your career, and any best practices or things that you found success in.
Yeah, I think there's no way to do any of the kind of work that we all want to do in global health or in human rights, for that matter, without partnerships. And certainly, the health sector brings together an array of partners that are different from many others. And obviously, affected communities are really at the heart of it. So, I was a member of ACT UP Baltimore when I was a resident. My late partner was very involved, and that for me was sort of the first teaching in really the power of community. And ACT UP had to take on the FDA, the NIH, the CDC. It was really quite extraordinary, and the FDA is a good example where ACT UP actually occupied the building, had taken a position that essentially people needed to be protected from, experimental drugs. And this is a community of young people facing untreatable disease and saying, no, thank you, we don't want to be protected. We are willing to take risks. We need to accelerate innovation. It was fascinating. We had an event at Hopkins with the ACT UP leaders and the woman who was head of the FDA antiviral division at the time when that happened, and she's now an elderly lady, but very much looking back on that history and talking about how transformative it was and liberating it was actually to sort of realize that this was the new face of community, and also that they were super smart and educated and had learned a lot about trials and were ready to debate things like placebo controls and open access and parallel track community trials. And I think the rest of global health really had to learn from HIV, how to do that. That is really where it began.
There's a question here.
Thank you so much for the talk. I'm Cyan. I'm a doctor from South Africa and did my master's in public health. So I was really interested when you spoke about the cholera outbreak, also because in the news recently, I don't know if you've seen, but South Africa has a cholera outbreak. And it's directly linked to, we've had a decade of extreme corruption that has resulted in our power grid basically failing, and so none of the water filtration systems are working, and our healthcare facilities are not spared the result of, they call it load shedding, power cuts, and so our healthcare workers are battling really severe conditions, particularly those in the state sector. And I think what sprang to mind when you shared that is that you've just had this incredible career where you've been able to do advocacy, lobbying, really taking into consideration political determinants of health. But I'm thinking of so many of my colleagues back home in SA who right now are working in facilities where the power keeps going off and they lose the patients connected to ventilators. It's a disaster. The water's full of cholera. And I think, where does that capacity come in to self-organize and actually draw attention to this as an important human rights violation? Because I think I'm so encouraged by your story. I'm just wondering in my own mind how we self-organize to actually, I guess, alert the international community that this is a health issue, because right now load shedding is seen as a power political failure.
Yeah.
It's not really seen as a health issue, but its effects are manifested in our healthcare system.
Yeah, yeah. Well, I think, there is a proud tradition in South Africa of kind of, there was a significant part of the fight against apartheid was also about the health inequities and health disparities. And South Africa has a very articulated, as you know, human rights tradition and culture. I think what's been so challenging is that, this is the Rainbow Nation. Now you have an ANC government. The sort of so many aspects have changed, and yet, the capacity to respond. It's been so striking because this. I remember when it began a couple of years ago, the thinking was, well, this is going to be resolved quickly, and it's just deteriorating. So yeah, I think probably the unions, COSATU, played such an important role in taking down apartheid. I think this is going to be one where the healthcare workers are going to have to organize as a force to move on this. Zimbabwe, I worked, the people who hosted us and really made our whole investigation possible was the Zimbabwe Association of Doctors for Human Rights.
Yeah,
Zadar. Yeah, are you a member?
Yeah, for a long time.
Well, let me tell you, they were awesome.
Oh, yeah.
They were absolutely awesome.
Farage and all those guys, yeah.
Yeah, and
women class, yeah.
yeah, and courageous. I
Yeah,
mean,
yeah,
really
very
courageous.
courageous,
Yeah.
I think,
Final question?
final question? Is there a final question?
Somebody right there.
Okay,
He's been waiting.
final question.
Hey,
Sorry.
I'm Max, postdoc here at Stanford in epidemiology, and
Oh, great.
thank you so much for your wonderful conversation. So I had a more personal question. How was it for you seeing Dr. Fauci 40 years ago
Yeah.
in charge? And now, I know that at that time, when the HIV epidemic was raging, he was very much criticized by the LGBTQI+ community. So how has that been for you, seeing him now in power for the corona epidemic? Did you disagree with him then, and did you disagree with his proposals now?
Well, I think what happened in those early years was that, it was a genuine crisis, and we did not have a responsive government. So, there's a lot of people who have very, very kind of warm and positive remembrances of the Reagan years. Not the people who were living through that fight at all, And I think what really emerged with Fauci was that he very quickly understood, first of all, that there was no keeping these people out of the room, and that there was also a real advantage to working with them. And he started doing that very quickly. And I was living in Thailand and working in Thailand when a lot of this period was happening, so I didn't necessarily see it. But then I went to one of the early international AIDS conferences, and there was an incredible young guy named Mark Harrington, one of the ACT UP founders, who introduced Tony. And then Fauci gave a talk about the immunopathogenesis of HIV, showing Mark's lymph nodes. And it was such an extraordinary moment, chilling in a way, and we all kind of looked around like, that is incredible, and they really embraced at the end of that talk, and you just felt like, okay, there's a new coalition here, this partnership. This is a partnership that's going to work. And then, of course, there was this long, hard period. It lasted a very long time, 15 years, from 1981, the identification of the virus, to 1996, when we finally had triple therapy. It took over 800 clinical trials, and lots of people signing up and doing badly. Trials that nobody survived, just an incredible array of studies to finally get to triple therapy. And it cost billions of dollars, and there is no way that we ever would have gotten there without his leadership. and without his ability to work across the aisle and, you know, work with both Bushes and Clinton and Obama, and then of course with Donald Trump, you know, you saw for the first time somebody who was just not going to listen to the science, and who was not going to pay attention to the evidence and put forward, you know, harmful approaches, hydroxychloroquine, you know, just bleach, really, you know, crazy things. And Fauci now, I just was with him not too long ago, is a liberated man. It's like unbelievable. He's such a delight to talk to. He's so happy that he can speak his mind. But he was driven out of office. He was not ready to retire, even though he's 81. Really by Rand Paul and this whole other group of Republican extremists around him. And he did not want to spend the last part of his career, you know, under subpoena and under indictment and being harassed by these people. And that is partly why he left. And, you know, that to me is...
He still needs security, though.
He needs security. Yes, he does. Yes, he does. Yeah, yeah. I mean, he, and his family does, too. Yeah.
I think we'll end it, and I'm going to thank both of the conversationalists for a wonderful session. Thank you very much.
Thank you.
Thanks, everybody.